Hello.
Sir, minute, 1 minute. So, good evening, everybody. So today we will have an interesting sessions, and with us our eminent speakers and all the panelists here for today's evening. And I am Dr. Gunadhar Padi, consultant coordinator, and the chief transplant and heart lung transplant coordinator in Apollo Hospital, Navi Mumbai. So with this, we'll be starting our today's talk. The today's session will be on very interesting on the nutrition. So basically, today we have eminent speaker, Dr. Subal Dikshit sir. So sir needs no introduction. Basically, sir is the chief intensivist director, and he's basically working in Sanjeevani Hospital and MGM Hospital, Pune. So we are glad to have him here today in our this panel discussion and the today's program. So I welcome you, sir. Today's program on Apollo Mumbai Critical Care Learning Network. And with us, my co-colleague, Dr. Akhilesh Tandekar is consultant intensivist, Apollo Hospital, Navi Mumbai. And with us, our eminent panelist. So Dr. Rabindra Reddy, sir. Sir is from Hyderabad Care Hospital, and he needs no introduction. Basically, he has special interest on diet and nutrition. That's why we have called him here. And with us, Dr. Sumit Rai. He is the chief intensivist from Canberra Hospital, Australia. And with us, Dr. Khalid Khatib from SKN Medical College, Pune. So I welcome all the panelists to this interesting and interactive sessions. And with us, our dietitian, Pooja Lakhani. So she will be going to speak on a very interesting, some of the aspect of the critical care nutrition. So with this, let's start our sessions and hand over to you, sir. Dikshit, sir.
Okay. Thank you, Gunadhar, for the warm introduction. Thank you for the invite, and thank Apollo team for asking me to talk on this topic on how to feed patients, or to feed or not to feed. Basically, we know that the concept of critically ill patients, all our patients are in a hypercatabolic state. They're in a rapid state of malnourishment. And if you really analyze by any way the dietitians normally do or the intensivists, we find that 50% of these patients are malnourished. Majority of these patients are of Crohn's disease, ulcerative colitis, malignancy, even those patients coming from the old age homes getting admitted with chest infections, COPD, all these patients basically are very in a hypercatabolic state. They get admitted because of some disease process or pneumonias, UTI, and as a result of which they're malnourished, and 50% of these patients really malnourishment is very, very important. So to feed or not to feed, the question doesn't arise. All patients, you have to give nutrition, and nutrition needs to be given right from the start. And it is very, very important aspect as far as the management of concern of all other system support is concerned. Because we know that in case if you don't feed the patients, there is going to be a longer length of hospital stay, there will be higher morbidity, mortality, and muscle wasting is very important. Like in case if you don't feed, almost persons in this hypercatabolic state can lose a muscle mass almost about 900 grams per day. And therefore, a nutritional muscle component has to be a vital component of the multiple organ failure. But at the same time, it has to be an organ support, like what you give mechanical ventilation for lung, you give dialysis for renal replacement therapy. You have also got ECORs for CO2 removals. So all these other systems which are there, a nutrition prescription has to be planned within the first 24 hours whenever the patients get admitted to the intensive care unit. As we saw that if you don't feed the patients adequately, if the cumulative energy deficit, if you really see the table on the right hand side, if the cumulative energy deficit goes on increasing, that means if you don't feed the patients from day one after admission, then you find that definitely these patients are into a high chance of severe hypercatabolism. There are increased chances of immunosuppression, and these patients will end up into sepsis. There will be a longer length of hospital stay. There will be more amount of morbidity or mortality. Vis-a-vis, if you compare the cumulative energy deficit with less than 10,000 kilocalories, the chances of these patients landing up into sepsis or the mortality or the length of hospital stay or the ICU stay is also going to be on the lesser side as compared to that. So most important, timing in the initiation is crucial. We know that time is muscle as far as the cardiac is concerned. Time is brain as far as the stroke is concerned. Similarly here, for better outcomes, timing of initiation of nutrition support is important. So early feeding is very important in these critically ill patients, and the demand versus supply gap, what you see here, that really has to be kept minimum. And if the demand versus supply gap goes on increasing, the cumulative energy deficit goes on increasing, and as a result of which the outcomes also gets bad. We know that along, if you don't feed them with proteins, carbohydrates, lipids, calorie depletion, definitely there's going to be a loss in the lean body mass. And especially if you're dealing with a surgical patient, there will be an impaired wound healing. These patients can also be hypoalbuminemic. They can also have burst abdomens. Those patients of COPD, they can be prolonged ventilation. There will be difficulty to wean. Or these patients can also have suppressed immune suppression, and which can precipitate infections or sepsis, and therefore the mortality and morbidity will go up. There is early initiation of nutrition therapy is important, and as a result of which you have got the time windows as far as cardiac thrombolysis, stroke thrombolysis. Similarly here, it has given you 24 hours to plan the nutrition prescription and start initiating it to optimize almost about 80% of the calorie goals within the first 72 hours. Of course, specialty and these fancy forms of fish oils and glutamine are available. They have got very limited use into medical intensive care units, although they still have certain role into surgical intensive care units, where Dr. Reddy will agree in the panel, and if we will of course discuss it and we'll go forward. Most important for all the students, yes, not only these critically ill patients, you must see that studies have shown way back that even nutrition has to be given for even a stable patients who get admitted to the wards. Because in case if you compromise nutrition, even in these patients in the wards, the same principle applies, the increased length of hospital stay, morbidity, mortality. That's very important. Take an example of a simple fracture neck femur who is just been recovered, operated, and if you don't feed them, then definitely there will be weakness, there will be mobility problems, especially if the protein content or if the nutrition calories are not being given adequately to the patients. Or a patient of stroke who is just recovered, being shifted out, if the nutrition again gets compromised, definitely is going to be a problem as far as the mobility, the physiotherapy, and whenever he wants to do exercise. And now mobility and physiotherapy have played a big role, and their concepts of physiotherapy have also changed. Early mobilization is a part of the first care of all patients who have now been admitted to the intensive care units. So nutrition is an essential component as much as what you and me eat also eat daily. So nutrition assessment is very, very important. It has to be done early. We have got various ways to see the Nutrix score, which has been come up with different parameters taking into consideration the Apache or the SOFA. Indirect calorimetry is the gold standard and the best way to calculate, depending upon the energy expenditure and the carbon dioxide, oxygen consumption and the CO2, the subjective global assessment, the universal screening tool of the MUST, and the ultrasonographic muscle thickness is there, or the NRSVs. Commonly, if you really analyze it, most commonly, it has been the subjective global assessments or nutrition risk screening which is being used. But there are certain institutes in India and of course Bombay, I know of 2 institutes. I don't have any institute in Pune at least, but Bombay, there are 2 institutes where indirect calorimetry is being used. And that is a much more sensitive and one of the gold standard as far as calculating the nutrition prescription is concerned, although it is costly and definitely time cumbersome, but it is one of the gold standard and the most sensitive and the specific way to help us to plan the nutrition prescription. So the assessment initially guidelines have suggested that you should plan it. Does the use of nutrition risk indicator identify the patients who will most likely to benefit? Most important, they have said that yes, the Nutrix score or the NRS score, they have to be performed in all patients who are admitted to the intensive care units, for whom definitely if you think that the nutrition intake is not going to be sufficient, and definitely high nutrition support have to be given to these patients as early as possible, and they're likely to benefit from early enteral nutrition support, and that is very, very important. We did analyze it and did publish it as should the evidence which is generated from well-developed countries in the West, is it really helpful and applicable into this? And this came up into Clinical Nutrition, where I was authored along with Khalid also here. And we published this just a year ago. We took into consideration the Nutrix score. Mind you, it takes into consideration the age, the Apache, the SOFA, the comorbidities. The comorbidities is equivalent to the stress factor, what we were taking into consideration before, and also took into consideration the days in the hospital from day 1 to ICUs, and importantly, the inflammatory marker of interleukin 6. Initially, a few years ago, before the pre-COVID era, not all hospitals in India really could monitor the interleukin 6 levels, and therefore the exact formulations of the calculation of Nutrix score would have been deficient. But now, because of the COVID, almost each and every hospital, whether it's big or small or tertiary, is been doing the interleukin 6 level. Mind you, it's just the inflammatory marker to tell you severity. There have been limitations as far as this Nutrix score is concerned, because most of the things, interleukin 6 levels cannot be measured. And similarly, in non-English speaking countries, you also need to translate it and adapt it, the Nutrix score, into the languages. And this has got very limited availability in all the countries. And similarly, not all ICUs are quite still geared up, and they do not monitor the Apache scores or the SOFA scores in all intensive care units. And therefore, these are certain limitations as far as the use of Nutrix score into it. As I said, indirect calorimetry is the best whenever it's available. And most importantly, it is the best way to recommend it, even as far as the guidelines of concern. Initially, even the guidelines in the latest, so 16, 17, have also suggested that indirect calorimetry, it is the gold standard, and it helps you to exactly give you the exact amount of deliveries which is there. If you really compare indirect calorimetry vis-a-vis with the other forms of scores, or the age-old Harrison's-Benedict equations, what we were taking into consideration, there have been inaccuracies as far as the delivery of nutrition support by almost about 60% into these patients. And with the advent and availability of indirect calorimetry, almost the nutrition prescription can now be optimized to almost about 90%. Mind you, it works and calculates upon the energy expenditure, and also based upon the requirements of oxygen and the generation of carbon dioxide. And definitely it was found that it is much more sensitive as well as specific. Although there is certain ventilators now which tells you the energy expenditure. To my knowledge, there is a GE Care station which tells you the energy expenditure, the carbon dioxide generation, as well as the oxygen consumption. So indirectly, it also tells you the calorie deficit and the calories what really need to be optimized. And that's one of the ventilators. If certain institutes have the luxury of using it, definitely, even if they don't have an indirect calorimetry, they can plan and optimize the nutrition prescription in a much more efficient and a much more precise way, so that it can be tailored from patient to patient. Mind you, nutrition assessment is very important. And in case if you don't feed the patients and a proper assessment is not done, then definitely you're going to compromise the care of the patient as much as you tune the ventilator or decide the dialysis prescription, the antibiotic protocols for de-escalation, and monitoring the antibiograms. These are very, very important. And as I said, indirect calorimetry is the best, and it has to be used always. It is much more effective, and you should start off with 25 to 30 kilocalories, depending upon the ideal body weight. Now, how to feed the patient? The route is very, very important. And most important is to use the gut, and the enteral route of nutrition support is much more important. There have been certain benefits into those patients where the baseline, those who cannot feed, their total parenteral nutrition support was considered. But mind you, the concept of total parenteral nutrition now has moved away from total parenteral nutrition support to partial parenteral nutrition support or supplemental partial parenteral nutrition support. The source of nutrition, all of you like what you and me eat, is the thali, but here it needs to be supplied. The source is given from carbohydrates in the form of glucose, of course, lipids, and proteins in the form of amino acids. And mind you, electrolytes, trace elements, and vitamins also play a very equal important role. Mind you, carbohydrates like as well as the amino acids give you about 4 kilocalories of energy, and lipids, of course, they give you 9 kilocalories of energy. And now lipids are equally important because there have been myths and conceptions that yes, lipids increase infections, total parenteral nutrition increases the infections. But mind you, no, they don't increase infections. But mind you, using lipids into a smaller quantity or a smaller volume can deliver more number of calories, especially you want to have or feed the patients with a cardiac cachexia, especially if the patient is there with a renal failure, with a fluid overload. You don't want to lead them, but he needs to be given nutrition support. You can give a small volume of lipids, but at the same time, it will help you to give more number of calories. And mind you, the entire prescription does not just depend upon giving carbohydrates, lipids, amino acids. It has to be a combination along with the liquid, the electrolytes, the trace elements of selenium, magnesium, or zinc, everything. And the most important form is a combination, which is important. And I would definitely stick with the fancy forms of nutrition support of glutamine and fish oil and arginine, which I'll cover it up in the following slides during the talk. The ratios can vary from person to person. This is what a standard of 50s to 30s to 20, where carbohydrates forms about 50%, proteins about 20%, and fat about 30%. But mind you, in certain subset of patients, you need to modify it. For in patients of COPD, you don't want the carbon dioxide production to go up, so the carbohydrate content will go up. The protein content will also go up. It will also vary in persons of trauma, burns, or polytrauma, or in acute severe pancreatitis, when you need to give more number of proteins and more number of calories because of associated comorbidities, or a diabetic patients where you need to reduce it. So it's going to be tailor-made. For this, definitely giving nutrition, it has to be individualized. That's what it has to be a good rapport with your dietitians, and therefore the dietitian has to be available with you on all your rounds, and the nutrition prescription really needs to be planned in consumption with him or her on round. As I said, the enteral nutrition support is the easy form. You must use the gut or you lose it. It is much more cheaper physiologically. It prevents the translocation. And most importantly, since it prevents translocation, it also helps to avoid the complications of the migration of bacteria. Because in case, if the histopathological studies have shown that, yes, there will be villus atrophy in case if you don't use the gut, and that will break the defensive barrier of the intestine, and that will then promote the bacterial translocation to precipitate infections, and the complications will occur. This is the standard which has come up from any textbook. How will you start feeding the patients? As we said that, yes, definitely all assessment needs to be done on admission. The nutrition prescription as much should be planned as fast as possible. And definitely you must see that once enteral nutrition has been initiated within the first 24 hours, of course, start off with full strength, the age-old concept of starting with test speeds, 50 ml today, then 100 ml tomorrow, 150 ml. Those concepts have changed. Definitely start off with a full strength concentration. See that, and don't hesitate to use prekinetic, prokinetics, and in the form of metoclopramide and erythromycin, and try to reach at least 80% of the calorie goals, what is required for the patient within the first 72 hours, by 72 hours, and assess 12 hourly. Of course, once you have met the goals, then that's fine. You can just continue to feed the patients enterally. But mind you, in case if you find gastric distension coming up of a large number of gastric fluid regurgitation which is occurring, then please use prokinetics, and then continue to feed the patients by reducing the rate of feeding by half, or then consider to use the post-pyloric feeding with the help of a jejunal tube or with the help of a feeding pump, where you can control the rate of feeding to the patients. The deficit number of calories, in case if you definitely cannot give or achieve 80%, then you must use the parenteral nutrition support or supplemental parenteral nutrition support to bridge the deficit number of calories, so that you don't compromise the nutrition prescription. So this is where the role now really comes up of total parenteral nutrition. The definition has changed. There is a very few subset of patients who require TPN, but mainly it is supplemental parenteral nutrition or partial parenteral nutrition support, which plays a very important role to bridge the deficit number of calories, so that you don't compromise the nutrition prescription in any of these patients. Of course, the plan of nutrition, we said enteral is the best form, parenteral in very, very few percentage of patients, and the most favorite combination is enteral plus parenteral, or sometimes partial parenteral nutrition support in case if you cannot bridge the deficit number of calories. And combination is very, very important. And along with the combination, bridge and give the exact number of delivered to the calories, control the electrolytes, check the electrolytes, have a very meticulous glycemic control so the sugar levels are kept properly. Definitely use pre and pro kinetics so that the motility also is maintained, and use post pyloric feeding so that the aspiration goes down. And definitely once you have achieved the feeding, definitely remember to titrate the doses of prokinetics where you have been using. Otherwise, later on, you'll be thinking why the diarrhea is also getting precipitated. And that's what is very, very important. And see that the calorie deficit or the cumulative calorie deficit does not go on increasing. There are very few subset of patients who need parenteral nutrition. Those who have got a real bad gut functions or a major intestinal resection, a large number of meters or feet of intestines have been removed, a very advanced form of ulcerative or a Crohn's disease, there is severe malnourishment, so those who are not anticipated to eat orally for a few days, and those who require a very aggressive nutrition support, who's going to undergo a major surgery, especially in those of malignancy, or a malnourished, severely malnourished patients who is going to be optimized, those are there. As far as the glucose control, yes, there have been various thoughts. There have been the intensive insulin therapy, which came back way back by NEGM from Greet Vandenberg, where she studied patients of the post-operative patients of CABG and tried to keep the sugar levels between 80 to 120. Definitely, there was associated with hypoglycemia into it, but this was backed up by the nice sugar levels from Australia, and they said that the sugar levels should be kept between 150 to 180 levels. And I had the honor to work and even the privilege with Dr. Ravinder Reddy, Dr. Yatin Mehta, and few dietitians also. We came up with the Indian dysglycemic guidelines for control of sugars, and we published in the Indian Journal a couple of years ago. And we have said that the sugar level should be kept reasonably well under control between 150 to 180. And this applies across the board of all spectrums of intensive care units, may it a burns patients or a polytrauma or a head injury, neurosurgery, renal replacement patients, or even those patients who are hepatic transplants, post-transplant also patients. All patients, the sugar level should be kept reasonably well under control. In these guidelines, we have recommended that the sugar level should be kept or monitored at least 7 times daily in these critically ill patients. That's very important. And of course, do not forget to calibrate the glucometers. That's very, very important. Mind you, for the sugar control, it is very, very easy to achieve in case if you give a dual energy, which is a combination of glucose plus lipids, and sometimes fish oils are used to again lower the insulin resistance. But mind you, into very subset of patients of polytrauma, burns, or advanced malignancy patients or traumatic brain injuries, but no longer these fancy or the immunonutrition is no longer being used into medical ICUs because of the redox trial, which came up because of precipitation of renal failure, or because on in patients of septic shock. So what do the guidelines say? I'll go through it. Initially, the guidelines say that in case if the feeding is or the blood pressure is not on the lower side, stop feeding. I agree with that. See that the mean arterial pressure is approximately above 60, 65 to start feeding. Definitely, they have again suggested that in case it's there will be chances of paralytic ileus, there will be mesenteric ischemia, there will be gut hypoperfusion. But now these guidelines in 2012 and 16, they later said that you can start feeding the patients as long as the fluid status of the patient is optimized. Once the fluid has been optimized, the MAP is also optimized above 65. Then, and when you have got a reducing doses of vasopressors, that is one of the things they have said for the definition of optimization of the fluid status into these patients. And of course, do not use here enteral nutrition support is the best way to start initiation of nutrition support. The guidelines again define severe nutrition support into those patients, those who have got a BMI of less than 18, or those who have got a weight loss of 10 to 15% within the last 6 months, or there is a class C in the subjective global assessments, and the serum albumin levels when there is no evidence of hepatic or renal dysfunction of less than 3. And mind you, pre-albumin levels are one of the most sensitive and specific here, but not all again units can monitor the pre-albumin levels into the lab. So albumin was taken as one of the indicators into it. And whenever you are starting nutrition support, as I said, as the guidelines even said, plan the nutrition prescription within the first 48 hours. Once the patients get admitted into the intensive care unit, it requires a full assessment. It requires time. You need to plan the nutrition course along with the dietitian. And in case if you have the luxury of indirect calorimetry, it is a much more better way to do it. And start off by giving about 25 to 30 kilocalories of ideal body weight. And you should use a combination and try to use and achieve at least 80% of the calorie goals within the first 72 hours enterally. In case if you cannot achieve it, definitely use supplemental parenteral nutrition support to bridge the deficit number of calories. And of course, the protein content should be approximately about 1.5 grams per kg body weight as per the guidelines. But in those patients who are dealing with a higher Nutri-Score, for example, in burns or in trauma, polytrauma patients, or these patients may require higher protein content, even up to 2 grams of per kg of ideal body weight. Now, which route of feeding they have suggested, whether it should be a gastric feeding or only precisely, there is no significant difference as far as the efficacy, whether you are starting with a gastric feed or a jejunal kind of feed. But mind you, those patients who cannot tolerate the gastric feeds, or those patients who have got increased chances of regurgitation which are coming up, or those who cannot protect the airway, it is always better to use a post-pyloric feeding or the jejunal kind of feeding, and definitely try to optimize it enteral route of nutrition support over a period of time. Enteral, as I said, is the preferred route, and it is one of the best route to give it. And because all studies have again shown, even vis-a-vis compared, that yes, it reduces the length of hospital stay, morbidity, it is quite cost effective and very, very important in these patients. Whether enteral or parenteral nutrition support should be considered, and they are usually suggested to use enteral over parenteral nutrition support. And in majority of the patients, the use, as I said, is only limited only to supplemental parenteral nutrition support into the subset of patients to bridge the deficit number of calories. Should exclusively parenteral nutrition support should be used? No. Exclusive parenteral nutrition support should not be used into all medically ill, critically ill patients, and you should use a combination of enteral plus supplemental or pure enteral and what is there. And definitely these have shown, the results have shown that the morbidity as well as the mortality rate has also gone down in case if you do not optimize the prescription into these patients. So using a combination is the best way. You see that the patient is not into intestinal obstruction. There is no amount of severe shock. The fluids are optimized. The CVP is maintained. The MAP is above 65. There is no gut ischemia unless the strong contraindication is that there is a severe intestinal obstruction. The patient is going to be taken up for surgery, or a major intestinal resection has been done, or a major gastric surgeries have been done, or a partial gastrectomy or major esophagogastrectomies have been done. In these situations, you can again discuss it and with the surgeons that these patients sometimes can again come out of the OT with a feeding jejunostomy and try to achieve and start enteral nutrition support jejunally and try to start feeding the patients. Now we know that nutrition support, initially we still have the concept of relatives coming to the hospital with bananas and apples and XYZ things from home. Of course, these are the kitchen feeds. The kitchen feeds are not good. I'm sorry to say, but that's the reality when you're talking science and scientifically. Kitchen feeds and the best forms to feed are the polymeric available, commercially available formula feeds, and the peptide based. And even we have got the fermentable soluble fiber based which are there. The various studies have again suggested, and the ISPEN guidelines have suggested, that commercially available standard polymeric feeds, they have to be used in all patients, whether it's a medical ICU or a surgical ICU, in initiation of enteral nutrition support in all the patients whenever we are using it. And various studies which have again suggested blenderized versus using the kitchen feeds. The kitchen feed, the problem is, one, you don't know the exact number of calories which are being delivered to the patients. You don't know how they have been prepared. You don't know what is the mixing content of it. You don't know the osmolarity or the viscosity of it. But at the same time, if you compare it with the commercially available formulas, you know the viscosity, you know the osmolarity, you know that the exact number of calories which are being delivered to the patients, and the exact number of proteins, the carbohydrates, and the lipids which are being delivered to the patients. And these are the things which will not precipitate much amount of diarrhea. Mind you, the exact delivery of the nutrition support is going to occur as long as you are using the scoops which have been delivered and the feeds are being prepared by the scoops which are being given by the company, because every scoop or every tin or the sachet of whatever nutrition support of any company use it has a medical prescription, and the contents of every gram or a per scoop or per sachet what is being delivered to the patient. And therefore you must know that you must also have a definite assessment of for us how many sachets and how many scoops are going to be required, and that is very, very important. And the chances of precipitation of loose motions is not every time because of the feed. Mind you, the tube clocking is very high, especially if you are using a high osmolar in kitchen feeds and not much with the commercially available formula feeds. And of course, when you're feeding it, see that before feeding and after feeding, you have to flush the tube, that's with simple water, and see that if the feed is being prepared and if you're using the gravitational bag or a feeding tube, see that the hanging time of the fluid or the prepared feed is not more than 6 hours to 8 hours. That is very, very important in order to avoid complications. Diarrhea is one of the important things which always people keep on saying. Diarrhea is not caused every time because of the feed, but mind you, it could be because of the prolonged use of prokinetics, what you are using. And these critical ill patients have been in intensive care units on XYZ, obtain number of antibiotics for a long period of time. So my friends, always keep in mind C. difficile infections or pseudomembranous colitis. You have to rule it out, and definitely that has to be taken into consideration, and look for other toxicities of any other drugs what you have been using, which is there. The guidelines have again suggested that parenteral nutrition support, be it in any form, whether it's burns, trauma, head injury, everything, use of parenteral nutrition support is the utmost important. Supplement them, and sometimes only in those patients, those who cannot tolerate, as I said, you should divert it into the lower intestinal tract. But you can definitely, there is no study or no things which say that it has to be initiated only lower down. No, you can start initiating the feed from the stomach, and in case if the patients cannot tolerate it, there is intractable vomiting or some problems, then you can divert it into the post pyloric kind of feeding. Please assess all your patients as per the guidelines within the first 24 to 48 hours. Have the nutrition prescription ready and try to achieve almost 80% of the calorie goals within the first 72 hours to have and reduce the morbidity as well as mortality into these patients. Give them adequate number of calories and proteins, about 1.2 to 2 grams of proteins may be required. Of course, higher may be required in patients of burns or trauma into these patients. And definitely not only give them macronutrients, but also take into consideration the micronutrient content, which is equally important. Now, the monitoring is equally important. Of course, the dietitian's role is not only to plan the nutrition prescription, but I personally feel the dietitian should also be involved into the monitoring of the patients or the delivery of the patients by discussing with the sister on duty and the doctors on duty, whether the amount of feed or the nutrition prescriptions of 8 feeds or 10 feeds, what you have planned for delivery of the patient, be it be of 100 ml or 150 ml or whatever it is there, whether they have been delivered to the patients. You commonly see patients always or relatives always telling us, "Humne feed laya tha, the feed has not been given." For why the feed was not being given, that also needs to be seen. Whether the patient was shifted for a gastrostomy, whether the patient was shifted for a surgery, whether the patient is now being operated and has been kept NBM. So mind you, you need to alter the nutrition prescription that time, and you need to have the bypasses of the nutrition prescription. But at any given of time, see that definitely you don't compromise the nutrition prescription. Look for the passage of flatus, see the radiological evaluations. Of course, see that there is no amount of distension or monitor for loose motions. And you can definitely see whether the patient needs a continuous or bolus feeds, or you need to give into a continuous infusion feeds needs to be given to the patients. So monitoring is important, along with the monitoring of the hemograms, the sugar, the electrolytes, the RFTs, the liver functions, the ammonia levels, and depending upon the need be of patient to patient, and that is equally important along with the hemodynamics of the patients. Now, whether these selected specialty formulas are available, we have got the branch chain amino acid content is more, especially when you are using it into hepatic failure patients. You have got especially post dialysis or the renal formulas which are available into it from varies to vary. We have also got the respiratory formulas which are available. So these disease specific formulas should be used only into medical ICUs and specialty indications only, and not as a part of all patients, and otherwise all patients should require other standard polymeric formula feeds. And depending upon the need be, you must also take into consideration the volume requirements of the patient, the volume state of the patients, how much amount of cumulative volume deficit he has or a cumulative plus deficit problems he has. So that's maintaining the U volumia is equally important whenever you are planning the dilutions as well as the prescriptions into it. And initiation should normally be done by standard polymeric formulas. Mind you, the immunonutrition definitely was being good. Initially, there was even the fish oils were being included as a part of the ARDS treatment in the anti-inflammatory because of his anti-inflammatory levels in patients. Definitely there have been studies and now they have been removed from the guidelines of ISPEN. Yes, definitely because of the generation of the heat shock proteins and also because of the decreased amount of translocation of bacteria from the gut. And these are various precursors for other good important amino acids. Definitely immunonutrition played a very important role. But the Daryl Hill trial which came up from there, it suggested that the redox trial, that it precipitated a renal failure into these patients of medical ICUs in patients of sepsis. And therefore, these patients who are no longer being now considered for use into medical ICUs where there is septic shock or where there is evidence of renal dysfunction. Mind you, there have been controversies and discussions from the Daryl Hill paper or the redox trial where Paul Wischmeyer, a good friend, again came up with a study where he showed positive results with glutamine into subset of patients. But mind you, as of now, into these fish oils or these glutamine levels or arginine for immunomodulation do not have a role into medical ICUs. Mind you, in surgical ICUs, definitely in patients of trauma, burns, initial levels of glutamines are on the lower side, and definitely in patients of traumatic brain injury or severe malignant cachexias, and these are in patients of burns. These patients are in the perioperative into surgical ICUs, which Dr. Reddy will agree. Still, there is a role and place for using glutamine into these subset of patients. But mind you, there should not be element of septic shock, or mind you, there should not be element of an renal dysfunction into intensive care units. As I said, they are no longer being recommended for immune modulation formulas as far as the evidence and the guidelines have considered. Now, the various peptides or the easily digestible, partially digested mixed formula feeds are also equally available. Mind you, they should be again reserved for use only into these subset of patients who cannot tolerate the standard polymeric formula feeds, because these only should be used by patients of malabsorptions, ulcerative colitis, Crohn's. There is persistence of diarrhea or malabsorption is there, and therefore they should not be used into all patients just to avoid a diarrhea. To avoid a diarrhea, you should not use it, and you should use it only in reserved form into a very specific number of subset of population. And similarly, use these fermentable soluble fibers can be given in divided doses only if there is evidence of diarrhea, but just to avoid diarrhea, it should not be used. Remember, as I said, macronutrients are important where you give good amount of proteins, but along with the use of macronutrients, you have to supplement the micronutrients, which are equally important. The various vitamins, the copper, the selenium are equally important because they play an important role as far as wound healing in surgical patients or difficult to wean patients in mechanical ventilation, and even patients of burns or trauma or patients of liver cirrhosis who've been on long-standing alcoholics where there's a magnesium deficiency. And this will all, if you give it, then there will be a decreased chances of precipitation of the so-called critical care neuropathy, which really occurs, which we don't know why, but it's usually a cocktail deficiency of multiple or irregular proper nutrition support, which has not been given to these patients. Of course, now various apps and technologies been available. I tried to use it into my ICUs for precise delivery using artificial intelligence. Definitely our chances improved. Definitely our nutrition prescription was much more better. And we did come up with the A-Star Nutrition app along with the PhD colleague, along with the MIT Institute of Technology. And just yesterday, last week, we have been granted patent from the Intellectual Property of India for planning on delivery of nutrition prescription. And therefore, my friends, as I said, Not all fingers are together and one and the same. Not all patients are one and the same. So the nutrition prescription needs to be planned within the first 24 hours. They have to individualize it. See that you give nutrition support precisely with precision, with a real feedback time and a dynamic kind of data which is being collected. It has to be monitored, not only planned, and so as to reduce the morbidity and mortality into patients. So thank you very much.
Thank you, sir. Thank you for a wonderful talk. I think now we can take the questions. So
I think you can start the panel, and the panel itself will have all the questions coming in.
yes.
Yeah.
So I just wanted to know from the other panelist perspective, the role of feeding in the critically ill patient. So Dr. Ravindra Reddy, sir.
You can hear me. Thank you very much. Can you hear me?
Yes, sir. Yes, sir.
Okay. At the outset, Dr. Subal, an excellent and a very informative and insightful lecture.
Thank you.
Quite a few points which I was not aware of, I learned. Thank you once again. Now, one of the pivotal points in any patient who is admitted to any ICU, irrespective of the cause for which the person is admitted, is actually to reduce the inflammatory process, right? Because the gut is a driver of inflammation, and the only way we can do that is by enteral feeds. Now, we all know that there is some element of gut dysfunction in patients who are critically ill or admitted to the ICU, or any ICU for that matter. And hence, it's better to actually give the patient minimal enteral feeds, or what is called as trophic feeds. Start at 10, 15, 20 ml, and gradually progress it every 12 hours, monitor the patient. Now, the good thing about this is, even if the patient is on multiple inotropes, but a stable level of inotropes, and the mean arterial pressure is at 50 and above, then we can start minimal enteral feeds. Now, if we inherit a patient who is also malnourished, and the guidelines say that we need to start parenteral supplementation very early on, because trophic feeds do not give calories, even though they maintain the gut integrity. But if the patient is not severely malnourished, then we can wait for 4 to 5 days. In the meantime, if the gut is not able to function or tolerate the adequacy of both calories and other fluids, then it's better to supplement parenteral nutrition. But the pivotal role is actually the enteral feed, because gut is a driver of most of the ill effects which we see in the ICU. And one ways to actually dampen or the anti-inflammatory effect is actually through enteral feeds. Thank you.
Yes, thank you, sir. So welcome, Dr. Khalid. So what is your view on critical care nutrition?
Hello. Yeah, one comment which I read was, how will you measure by ultrasound muscle thickness, which muscles you will use? And I think that was how one of the question was. The muscles that ideally you need to measure are the quadriceps. You can measure the quadricep muscle, or if you use the lower limb muscle, you can measure gastrocnemius or tibialis anterior. And then you have to follow this muscle thickness over the next 2 to 3 days. And that is how I think it will be, you will be able to measure. But it is a steep learning curve, I think. You must be able, before you can do ultrasound of muscles, I think you will have to learn a little bit about measuring the muscles. Yeah.
How about body composition analysis? Do you do body composition analysis routinely? I would like to know from you, and other panelists also can contribute.
So before we go to this question,
Yeah.
so let me just have the perspective from the dietitian side also. So with us, Pooja is the founder of one of the nutritional program, the Poshan Mantra Private Limited. So Pooja, you are there?
Yes.
So,
am I audible?
Yeah. So what is as a dietitian? You have the role of the dietitian is very important. So yes. So what is your perspective in this?
So I feel from the guideline point of view, a lot has been beautifully covered by our presenter and other panelists. The only thing I'd like to add in here is, a lot of times we do perform the nutritional status assessment. And what we find is, because SGA score and other scores have their own limitation, they rely on weight loss, they rely on nutritional intake, gastric symptoms. These may not be present in a major population of patients who are admitted to the ICU, especially those who are admitted with acute conditions. So an acute trauma, acute injury, or if there is acute pancreatitis, these patients typically may not have any symptom before they were admitted to the ICU, and hence they will essentially be assessed as well nourished. Now, if you look at the guidelines suggest that for a well-nourished patient, you can wait for EN and PN from 7 to 14 days. But what we need to focus on is these patients have a very, very high catabolic activity. Their demands are very high, and hence a serial assessment should be done, especially in patients who are deemed well-nourished at the time of admission. For chronically ill patients or for malnourished patients, we have got guidelines which tell us when to start, how to progress, how to proliferate. I feel the population, the ICU population that gets majorly ignored are the ones who are acutely ill. Also because initially their clinical stabilization takes away all the focus and concentration. So what needs to be done is a routine assessment, is a serial assessment, how the patient is doing in terms of the clinical progress and as well as the nutritional status. One thing which is coming up and is gaining a lot of focus in our fraternity is the nutrition focused physical examination, where a dietitian looks for physical signs and symptoms of fat loss and muscle mass loss. And this is very, very subjective. You may rely on weight loss and nutritional intake and all of that, but look for signs of fat and muscle loss. And these are very simple. You look at the periorbital region, you look at the scapula, you look at the calf muscle thickness and all of that. And these are subjective, very easily accessible parameters that can guide when to start and how to progress your nutritional plan of care. Sorry.
Sir, what is your view on bioreactance and bioimpedance? Because nowadays a lot of newer modality of monitoring has come. So any idea, sir? Dikshit, sir?
No, honestly, I'm not monitoring these things. Usually I monitor is the serum albumin levels, the sugar levels, and sometimes recently I've asked my students in my intensive care units to monitor the muscle thickness. We are still into the learning phase into it. We have just started monitoring the muscle thickness for the patients, what Khalid just said. But I'm not using any bioimpedance. I think Dr. Ravinder Reddy will throw better light onto it.
Dr. Sabal, yes, thank you. We were using BIA. We were also using the chair stand test. We were also using the gait speed test. Those who walk less than 800 centimeters or 0.8 meters per second for both males and females. And for hand grip strength, those who had less than about 12 to 15 in females and less than 20 kilograms in the both dominant and non-dominant hands is a muscle function. And those who were, how many times they were able to stand up and sit in 30 seconds as such. If they were able to do less than 3 times in 30 seconds, then we know that their muscle function is inappropriate. These are for the muscle functions. Now for the muscle mass, bioelectrical impedance, which is relatively a non-invasive one, unless the patient is in CKD, or the other invasive ones are the DEXA ones, but there's an element of radiation. So also MRI, which is quite costly. And if the patient is undergoing a CT scan for some reason, then the lean body mass at the level of L2 vertebra, especially at the abdominal muscles and including the psoas, it gives us a very good indication. In fact, Dr. Adarsh Chaudhary from Vedanta has got a prospective study on this, showing that those who had a less, it's called a skeletal muscle index, those who have a very low skeletal muscle index, their complications were quite high, even though their length of stay, their complications were same, but the length of stay was quite prolonged as such. In our own study, which was, it was one of the theses of my student, it was picked up as the best thesis for 2022 in whole of India. We did a hand grip strength versus surgical outcomes. This was a prospective open label study. Basically, we're just looking at the muscle grip strength and looking at the outcome both in terms of the surgical site infections as well as the stay in the hospital. And those who had a suboptimal hand grip strength, not surprisingly, showed that they had increased incidence of surgical site infections as well as prolonged stay compared to those with a normal grip strength. Coming back to the last point of ultrasound, as Dr. Subal has said, we are still in the learning phase. But in our hospital, instead of gastrocnemius and other things, they use the rectus femoris, mainly because there was our radiologist to whom I gave this article did it on rectus femoris muscle. And also it's quite easy to insonate. It's quite superficial, easy to insonate and actually look at the cross-sectional diameter of rectus femoris muscle, both pre, during, and then on the patient who's coming for follow-up. It's a very good thing, non-invasive, easy, can be done in outpatient if we can train ourselves. One of my postgraduates is actually trained in this, the one who actually has done the thesis, has trained herself on this. But then muscle mass, be it critically ill patients or in elective surgery, emergency surgery, or even transplant surgery has a very bad impact if the patient has sarcopenia. Dr. Subal, thank you.
Yeah, I agree with you.
Thank you.
So basically, bioreactance principles are quite useful in analyzing the muscle mass. Not only that, but we will also be able to identify how much is the edema, which way, how much is the water accumulation. Sometimes we really don't know how much is the water accumulation or the positive balance. So with these bioreactance methods, we will be able to delineate how much is the positive balance and how much is to be removed, and which muscles are sarcopenic, and what kind of exercises or physiotherapy can also be employed. So bioreactance will be a very useful tool, but it still depends upon how much is the energy that is being transmitted, how much is absorbed. It still has no variability. So it's still a matter of debate, but there are centers which are using these bioreactance methods to analyze the fluid balance and muscle sarcopenia and all that. So I would like to know from Dr. Sumit Roy. I mean, what is your practice about critical care nutrition in your organization, Dr. Sumit?
Thank you, Flesh. Firstly, it's a great talk, Dr. Dixit. Excellent talk. Very comprehensive.
You can remove the mask. Let us see you.
I'm in the hospital,
You can remove
so
the mask.
it's a bit difficult. So as far as the practice here where I work, I don't think it's any different from what Dr. Dixit has so beautifully explained. What we would usually do is start feeds within 24 hours. We're a very pro-feeding unit. So, and if our patient is hemodynamically stable, we actually go to goal rate feeds. So once they've approximated their feeds, that is because we know in critically ill patients, there is a significant period of time that their feeds are stopped, either because they're going to a scan, they're going to surgery, or whatever the reason might be. So even when you start goal rate feeds, you only effectively deliver between 60 and 80% feeds. But and that is as per the guidelines that we should try to aim to achieve around 70 to 80% feeds in the first 5 to 7 days. The only patients we are worried about, of course, is the malnourished patients, where our dietitian keeps us on our toes, really, by coming to tell us that we've not been feeding the patients correctly, or they're behind their feeds, and that way we're able to adjust our goal rate feeds. But we do continuous feeding by using an approximate formula, which there is no real difference between any of these formulas anyway. So we use 20 to 25 kilocals per kilogram as the goal nutrition for our patients at the bedside. And then within 24 hours, all our ICU patients are evaluated by the dietitian. I think just going back on, I think what some of the panelists have said before, I think the biggest concern is not the patients who are intubated, because I think everybody's good now at starting enteral feeds soon. think it's those ones who are not intubated but are critically ill and in our intensive care unit. We get them a diet plan, but we have no idea how they are eating because nobody really keeps a food chart of how much they've consumed. And as you all know, the critically ill patients often have significant lack of appetite. And they're those ones who unfortunately fall in through the cracks, where they aren't getting the nutrition because we expect they're eating and they've got a food tray in front of them. And we don't keep a very close eye on those patients. But that's all from me, and happy to answer any other questions.
Sir, one more question for you by one of our doctor, Dr. Swapnil. So high protein diet in CKD patients and on dialysis, sir. Any short tip?
I'm not a renal physician or a renal dietitian. I think Pooja is better sorted to answer that. I would have thought lower protein, but given their critical illness and depending on what their critical illness is and what kind of dialysis they are on, if they are on CRRT, which is commonly the practice in Australia, we wouldn't restrict proteins. If they are on intermittent hemodialysis, of course, that is a completely different issue. But I'm sure Pooja can answer that better.
Yeah, Pooja, from your side.
Thank you. So going by the guidelines for critically ill patients, even if your patient has a renal failure with or without dialysis, as Dr. Rai said, we do not restrict protein prescriptions or protein provision for these patients. The bare minimal that you need to meet for these patients is 1.5 kilogram per kg per day. Now, the challenge here is which kilogram, because if the patient is intubated, not able to move, if you do not know the accurate weight, your prescription may not be as accurate. One good way to go about it is know the usual body weight. So you could interact with the patient or ask the relative, reach out to the relatives and find out what was the usual body weight. Otherwise, you could measure patient's accurate height. There are many methods you could, which will help you eventually measure the height of the patient and go by the ideal body weight and plan nutrition prescription that way. 1.5 grams is bare minimal. Now, again, one problem which we face here is there is a high protein supplement which has been prescribed to the patient. In what dose and for how long is what is important. So a dietitian is planning that. There has to be a record of how much feed the patient is receiving. That record will tell you what is the calorie or protein deficit. If you're meeting 60 to 80% of your calorie prescription, that is where you're achieving your nutrition goals. 80% by first 72 hours and 70% of calories is what we need. So 1.5 gram protein per kg per day, whatever ideal body weight or usual body weight you have on record, and then auditing how much protein that patient is receiving every day. 80% within 72 hours of proteins and 70% of calories. If that answers, I mean.
Yeah, that covers everything, Pooja.
So really, today's discussion was very intense, and really thank you, Shubal Dixit sir, for your wonderful talk. And I think students must have definitely benefited out of it. And I must thank all the panelists today. I think we are short of time, already spent more than 1 hour. So with this, I would like to conclude the session.
Yes, just a last question from one of the distinct delegate, Dr. Hemant. So how to manage nutrition in a fluid restricted patient, say only 800 ml in 1 liter of this thing, like if you restrict the fluid, so how to manage the nutrition? Dr. Khalid. So if you.
Yeah, thank you.
Sir.
Thank you.
Khalid, sir.
Yeah. So what you will have to use will be energy dense and protein dense. If you are feeding enterally, then you will have to use energy and protein dense formula. And maybe you might have to add some, ideally some partial parenteral, or you might have to use some supplemental protein I think if going to restrict, that is the only you can give an adequate energy to the patient.
So Reddy sir. Sir, your views on how to manage the nutrition if the patient is being fluid restricted?
Yeah.
Sir, you are mute.
Sorry, yeah. So it is really a challenging scenario when the protein requirements are high, the calorie requirements are high, and on the other side, the patient is challenged as far as fluid is concerned because of cardiac issues or renal issues or liver issues. In such scenario, I think as the previous panelist has did mention, it's ideal to give at least 2 kilo. Some of the formulas are available which give about 2 kilocalories per ml. Personally, I'm not aware of any, at least in India, maybe they are, but not to my knowledge, that they're more than 2.5, no more than 2 kilocalories per ml. So we can perhaps give. At the same time, if the patient has no issues as far as infusion of fats are concerned, I actually give this patient, a parental nutrition, which is just about 1,000 ml, if I can get away with that. Because some of them are rich. At times, I have even given only pure lipid emulsions, intravenous lipid emulsions, to actually achieve the caloric requirements, being mindful not to cross 0.75 or 1 gram per kilogram body weight of fats in these individuals, whilst keeping an eye on serum triglycerides, because we don't want a lipemic serum in these individuals. So it is surely a challenging case, challenging scenario. But then at times, if let's say we calculated requirements are, for the sake of discussion, let's say about 2,000 kilocalories. And even if you are achieving 1,200 to 1,300 or even 1,400 kilocalories, perhaps it's all right, given the fluid restriction, because we don't want to fill the patient more and have the antecedent side effects of overfilling the patient, especially when the underlying dysfunction of either the heart or the lung or the kidneys or the liver are there. So high caloric formulas can be essential. At the same time, keeping a very close eye on these patients, clinical outcome, at the same time, the biochemical parameters to see if we are doing any good thing to the patient or the patient is on the right path to achieve a positive clinical outcome. Thank you.
So if I may just add to this, so if we pick up this one value of 800 ml and you have a formula which can provide 2 kilocalories per ml, you can easily achieve 1600 kilocalories, which I feel will fit into most of the patients' 70 to 80% of requirements.
Absolutely.
In this same planning, if you, for example, have a 4-hourly feeding cycle or a 6-hourly feeding cycle, then in this case, you need to probably give 3 feeds of a high calorie formula with 1 feed of a high protein formula. And that will help you meet the requirements in most cases. Again, I'm sure you all would agree that these fluid restrictions are not going to stay for the entire stay of patient in the ICU. They're transient. After about, say, 5 days, 7 days, we will have these fluid provisions being increased. And that is where you can increase your nutritional provision. But it's not so difficult. We've got commercially well-balanced formulas available, which will help you meet protein and calorie requirements within 800 to 1000 ml. There's just a combination that needs to be made.
Yeah, absolutely. Plus now we have got the pediatric 3-in-1 bags, which are also available with 384
Yes.
ml. So those bags also can be used into these subset of patients.
Yes,
Absolutely,
but
yes.
yes, that will help. But in most cases, we may not need that.
Yeah, I agree with you.
So, any more questions?
No, I agree with the CKD or any of the fluid restricted patients as well. I think as Pooja was saying, the most important thing is as far as I'm aware, none of the 2 kilocal feeds have enough protein. So you have to supplement the protein in some way. So when you do put them on that high caloric feed formulation to reduce the volume requirements, you have to think about protein, because you are unlikely to deliver the protein requirements for someone like that who's critically ill and who definitely needs more protein.
Yeah, thank you, Sumit sir. So I think we don't have any questions
So-
in the chat box.
So any message, within short words, if you all can give it to the students, any tips about nutritional delivery, nutritional prescription? Subal Dixit sir, from you.
It's very simple that don't
On your
neglect
side.
nutrition, plan your nutrition prescription, analyze patients, see that nutrition is started, achieve 80% of the caloric goals, and discuss everything with the dietitian.
Yeah,
And
multidisciplinary team.
take him or her along with you on the rounds for the nutrition prescription.
Absolutely, absolutely.
Very simple.
Yes, and empower them. Yes, yes.
No, that's very important.
So,
Yeah, yeah. Dr. Khalid,
yes.
Khalid sir,
Ravinder,
so you are on the mute, I think.
Yeah, I totally agree with Dr. Subal. A multidisciplinary team is much better. If we can have a nutrition support team, which includes everyone and nothing like it, because the benefits have been shown umpteen number of times, especially in the ICU. Because perhaps we as clinicians are not aware of many of the nuances in which the clinical nutritionists or dietitians will actually get away by actually feeding the patient to a much optimal level than what we can fathom as clinicians, because they are experts in these. So hats off to at least my dietitians, and they come up with amazing ingenious ideas, and we generally get away with feeding the patient maybe about 30% of the times resorting to parenteral nutrition, but at least 70 to 75% of the times you don't need to do that. As one of the panelists has rightly said, especially in if we concentrate more on calories, we might forget to give adequate proteins and amino acids. So at times we need to be mindful of that fact. So I echo what Dr. Subal has said. Think of nutrition in every patient, irrespective of the pathology for which the person is admitted to your ICU. Thank you.
Khalid sir, from your side. Sir, you are mute. You are mute, sir. Sir, you are on mute.
Another point, I think once we have calculated calories as well as proteins, I think you must not forget micronutrients. And that is where, see, that is what we must not forget. We concentrate only on calories and proteins, and these micronutrients, they might get lost in the whole scenario. So we have to also look at micronutrients and then supplement them in patients who are deficient.
Yes.
So that will take care of the entire nutrition. Yeah.
So any take Pooja from your side?
So it's been, I echo whatever my seniors and other panelists had to say. I'd just like to add this small bit is it's very important that you have a top to down nutrition management protocol as well. The way you have a protocol for managing a ventilated patient, a patient who's come post-trauma, post-surgery, there's a very beautiful pen down protocol and everyone sticks to it. It's important that you have a top to down nutrition management protocol as well. Which patient will require what mode of nutrition, when to progress, when to change, diarrhea, feed interruptions, how to manage, it's very, very important. And audits are also equally important. That's how you'll know if your protocol is working well. So I think I'd like to sum up by saying this.
Thank you.
the monitoring is also very important.
Sumit sir. So,
I
Dr.
don't
Sumit,
think I've got anything left to say. Pooja and everybody else has explained that very well. All I can probably conclude by is to say I don't think there is a dilemma in to feed or not. The dilemma is how soon to feed, and to essentially think about feeding early and using an enteral or a feeding protocol essentially, and involving a dietitian in every critically ill patient. Thanks.
Thank you very much. Thank you, Subal Dixit sir, for your presentation, and you come out of your busy schedule. I must thank you on behalf of our Apollo Critical Care team. And I also thank Reddy sir for your valuable feedbacks. Really, it was amazing. And I also thank Dr. Khalid. Also, I mean,
Yes.
your feedback on nutrition should also be emphasized. And I also thank Sumit sir for your insights. And with this, we would like to conclude the session and hope to see you again and again, because nutrition, the discussions are quite intense. There is a lot to discuss on that. Hope to see you again and again. Thank you for now today. Bye. Bye.
Thank you, sir.
Thank you.
Thank you.
Good night.
Thank you very much.
Thank
Thank
you.
you.
Very much. Bye-bye.
Thank
Bye.
Thank you.
you,
Bye-bye.
Pooja. Thank you, Pooja. Thanks.
Thank you, Pooja.